Yeah, I'm fine. Don't worry. Okay, he's just connecting at the moment.
Yeah.
Yes, sir, we are live. Over to you, Don, sir.
Yeah, okay. So good evening, everybody, and welcome to this latest webinar, which is going to be on carpal instability. And we have none other than Dr. Sudhir Warrier, who I don't think needs any introduction because uh, this is something he's been talking about for many years in various meetings. But I think especially for the postgraduate students, this is an area which causes much confusion, and I don't think you can have a better person to explain what we mean when we talk about carpal instability than Sudhir. And so over to you, Sudhir.
Thank you, John. Wonderful to be here and uh, continue with your teaching series. Um, the question that I had yesterday was, what do I talk about? And then this is what I was told, that there are going to be a lot of postgraduates, and these are the common questions that come up. So I'm going to try and address some of these. And it's really amazing when I look back that my association with Oref is 25 years old. Today, almost to the date, this was on the 3rd to the 7th September in 1995 that we held the COE in Sion Hospital in Mumbai. And I was fortunate to be able to edit my first leaflet on the proceedings of that meeting. John, that was really one absolutely wonderful experience to see the enthusiasm of all that were attending. And year after year, whenever you invited us, I could see that there's a whole lot of people who were very, very interested and constantly came to update themselves through the COEs. So this is really a great tradition. And John, thank you for keeping that up.
Thanks, Sudhir.
Now, when you talk about the wrist, and when you talk about wrist instability, anatomy is the king. But then you open a textbook and it kills you because there's so many ligaments, each one named differently in different texts. And in the same text, in two editions, you'll find names changing. So it becomes extremely important to understand some basic ligaments, know what you're looking at and what you're dealing with. So the first thing to understand is that the wrist is within a capsule. And inside the capsule, there are two sets of ligaments on both sides, on the dorsal and the volar side. These ligaments are the extrinsic ligaments and the intrinsic ligaments. Now, the intrinsic ligaments are the ligaments that connect to the adjacent bones. They're the tiny little ligaments that connect to the adjacent bones. So they're named according to their bones, and that's not hard to remember, and that's not important to remember either, because the instability arises from the extrinsic ligaments primarily, and then spreads into intrinsic ligaments. And when you see two bones going apart from each other, you know obviously that the intrinsic ligaments have given way. But the extrinsic ligaments are the ones that we need to understand. And if we look on the left, the volar side is seen, you can see the radioscaphocapitate ligament, an important volar ligament that strings up the scaphoid and keeps it into extension while attaching the radius to the capitate and allowing the scaphoid to rest on that. So that's an important ligament which is counterbalanced the ulnar side by the ulnocapitate ligament. So these two form a nice arch. There are two other major ligaments that you shouldn't ever forget. One is the long radiolunate ligament, and the other is the short radiolunate ligament. Now, these ligaments attach from the radius to the lunate as seen here, and these are the ones that hold the lunate really firmly and are amongst the strongest ligaments in the wrist. And we'll see some more about these ligaments as we go along. When you come onto the dorsal side, you can see that much of the radial styloid aspect has thinner and smaller ligaments, but the most important two ligaments are the radiotriquetral ligament and the dorsal intercarpal ligament, which runs from the triquetrum on the ulnar side to the trapezoid and the scaphoid on the radial side. So you know that these ligaments together form a large, strong structure on the dorsum, which also is like a one big trapdoor you can open out when you do P-surgery from the dorsal aspect. Now, we will see some other ligaments as we go along, but just remember that some of these ligaments are extremely important, and we'll be coming across these ligaments. The next thing to understand is the fact that the wrist is a load-bearing joint. These little bones are carrying the whole load of the hand on their heads, and the load can increase when you clench your fist and when you lift things. You're loading these again. So these ligaments have to prevent these bones from running away from each other, which is instability. So they need to keep them together. So if you picture this in your mind, you understand what is happening when we load these bones. Well, we always learn to identify these bones, especially as students, that she looks too pretty, try to catch her, but they don't look pretty during the exams. You can be sure about that. When you're flashed an X-ray of the wrist, you obviously start getting worried simply because you don't know the shapes of these bones, wonder whether they're right or wrong, whether there's something slipping there and twisting there or moving apart from each other. So you don't know these relationships because these relationships change with position. And you must understand that it's the scaphoid that forms a link between the proximal row and the distal row and works like a cam, not unlike the cam that you will see here. See this rod, it is an extension as the others. Now changing their relationship. So the scaphoid is the cam in between, and you're clear view when you do radial to ulnar deviation. So when you're doing radial to ulnar deviation, this is in full ulnar deviation. You can see the scaphoid is completely extended. And as you go into radial deviation, the scaphoid gets completely flexed. There it's completely flexed. So you see the ring pole sign when the scaphoid is completely flexed. And you find that this happens when you ulnar deviate the wrist. So if you look at the other bones now, you'll see there's not much change is happening. It's the scaphoid, like the cam that's moving, that keeps the relationships between the proximal and the distal pole intact, while allowing those other bones to move and give you ranges of movement. But when you go into radial deviation, the scaphoid always flexes. The scaphoid has no other place to go. Why does it flex? Because on top, you have the overhang of the distal radius. On the radial side, you have the radial styloid, which is the most distal part of the wrist, of the cup that is formed between the radius and ulna. So the radial styloid reaches far beyond, and that is the reason where because of which the scaphoid has no other place but to go down. So the space that remains. Now we are looking at dorsiflexion and palmoflexion of the wrist. When you look at this video, we'll see that once again. If you pay attention to the lunate, you can see that the lunate is not moving too much. You can't see much movement happening between the radius and the lunate. There's little movement there. How is the wrist moving so much? The wrist is moving so much because of the mid-carpal joint. And how much do we know about the mid-carpal joint? Very little. We aren't taught too much about the mid-carpal joint. So this is the importance of the mid-carpal joint. All of these movements that we saw gives you flexion and extension of almost 90 degrees, but an ulnar deviation of 30 degrees and radial deviation of 90 degrees. So this is the range of movements you're looking at the wrist when you're trying to treat wrists to get back ranges of movement. Out of this, we forget that the mid-carpal joint is an extremely important joint. And 60% of the flexion occurs here. And we saw that video, and we can remember that the lunate isn't moving too much in relation with the radius. It's the mid-carpal joint that gives you 60 degrees of flexion, 60% of flexion, and 30% of extension. So a large to treat a patient after a distal radius fracture, you may not, you may give him, you may start with wrist movements, but you may not see that much of movements happening. You can then concentrate on the mid-carpal movements. And if you concentrate on the mid-carpal movements, you can gain 60% of flexion, 30% of extension, which is good enough for normal function of the wrist. So look at that once again before you forget it. You should never forget carpal joint, which gives you a range of movement, which is known as the dart throwing plane of movement, which is from dorsiflexion and radial deviation to palmar flexion and ulnar deviation. So that's the plane of movement, which is entirely happening at the mid-carpal joint alone. Now let's get to some parts of instability. What happens when these joints and ligaments, which we spoke about, are not in harmony with each other. These, if you consider this young man as the scaphoid, the lunate is a little smaller, the triquetrum is the smallest of the lot, and they're holding hands. So those hands that they're holding are the ligaments that we speak about, the scapholunate ligament and the lunotriquetral ligament. These are, as we said, the intrinsic ligaments. As long as they're all holding hands and moving around in harmony, and playing, this is what is happening. So the three bones in the proximal row are holding their hands and they can move. But the distal row, if you notice, looks like one piece. And this is where there is the oval ring concept, which I like to think is a good concept to remember when you're treating carpal instabilities, because it reminds you that the distal row is completely fused or completely fixed with very little movement occurring, or relatively less movement occurring between the CMC joints at that level. Most of the movement is occurring between the radius and the proximal row, and the proximal row and the middle row. That is the mid-carpal joint. So when they're holding hands and playing around, everything is good. So that's how they look, happy and nice. Now remember, the triquetrum is the smallest of the lot. The scaphoid is the largest. It bridges the two rows of the carpus, and is the link like the cam. So what happens when the scaphoid and the lunate leave their hands? Well, when the scaphoid and the lunate leave their hands, where can the scaphoid go? That means there is a scapholunate dissociation. Where can the scaphoid go? It can only go down into flexion. And why does it go into flexion? Simply because there's no space anywhere else for it to go. So it will fall or flop into flexion. Triquetrum is the tiniest of the lot, and the triquetrum tries to look up at all times. So remember this in your mind, that the triquetrum wants to look up at the lunate and the scaphoid, and therefore always goes into extension. Always. Now it's holding the lunate, so it's going to take the lunate into extension. Simple to understand. Scaphoid has no place to go. He's going to go flexing. He's not holding the lunate, so therefore The lunate goes with the triquetrum. The triquetrum likes to look up because it's a tiny bone. It wants to look up. Always children like to look up like that. So that's what's happening. And you get a flex scaphoid, an extended lunate and triquetrum, which is known as the DC. Now, DC means dorsal intercalated segment instability. So all it means is that the lunate has moved out into a position which is not normal or dorsally. And the reason for that, you need to then find out. Commonest reason being scapholunate dissociation. So DZ is that. What happens if the other side loses the connection? So if the triquetrum leaves the hand of the lunate, which means there's a luno-triquetral instability, the scaphoid still has no other place to go. So we'll go down into flexion. But now the lunate is holding the scaphoid, so it will go with the scaphoid. And the triquetrum likes to look up, remember? So he's going to go back into extension. So the lunate now is looking down. So when you look at an instability that is on the ulnar side in the proximal row, this is what happens. You will find the scaphoid and lunate tilted down, which is called VZ or volar intercalated segmental instability. Now, having understood this, this is the basic thing. So you know that you've got to look at 2-3 things. Number one, where's the scaphoid? Look at the scapholunate angle. If the scaphoid is flexed and the lunate is looking up, you know something is there on the radial side, and that the scapholunate dissociation could be one of the causes. There are other causes, obviously, but this is the commonest cause. On the ulnar side, which is much rarer, you will find a VZ deformity because of the lunate now tilting down with the scaphoid. And so this gives you an idea of DZ and VC. From there on, you get other patterns. So what is the classification? A good simple classification. There are many classifications. A lot of names go with different classifications, and I can't stick with too many names and classifications because in a practical approach, I would like something that I understand simply. And the one that I understand very easily is these patterns. That is the carpal instability dissociative, which means within one row, within the proximal row, if the two bones left their hands or the ligaments have been torn, that means it is dissociated. This is a carpal instability dissociative. That means within the row, if in a transverse row, two bones have moved apart because of some pathology, that is a carpal instability dissociative. If there is movement between rows, that means all three bones are holding their hands, but there is a mid-carpal dissociation or a radiocarpal dissociation. This is called a carpal instability non-dissociative. Means the bones in the row are not dissociated. So that's easy to remember. There can be commonly a complex, that is carpal complex, where there are features of both a CID and a CIND, which means there can be a transcaphoid perilunate dislocation where there's both happening. It's dissociation in one row plus a dissociation in the other row. So you can have a complex dissociation as well. And the last is the carpal instability adaptive. When there's changes like in a distal radius malunion, there's a tilt of the bone, the lunate goes with that and the correct this. So it's an adaptive change. So you can see adaptive changes in the lunate or in the capitate or in other bones, depending upon a problem which is not within that bone or within the row of carpus. It is proximal or distal to that. So there is an adaptive change that can be there, which initially starts out as a correctable deformity and then becomes a fixed deformity. So that's the 4 different types. So CID, CIND, CIC, and CIA. So these are the 4 different types, and simple to remember when you understand what you're looking at. So we'll now come to the commonest carpal instability, and that is scapholunate instability. Now, scapholunate instability, you start looking towards the scaphoid and the lunate and try and see whether there's a space in between. Sometimes there's no space in between, but the patient still has pain. And where will you palpate? You will palpate just distal to the Lister's tubercle. So if you see the Lister's tubercle, just distal to that with the wrist in a little bit of flexion will bring out the scapholunate joint and present it to the dorsal surface where you can easily palpate. And if there's pain right at that spot, you know, just distal to the Lister's tubercle. On the radial side of that is the scaphoid. On the ulnar side of that is the lunate. Tenderness on the radial side would mean something to do with the scaphoid, that is a proximal pole non-union, or a cyst, or a ganglion, etc. On the right side, on the other side would be the lunate, that is towards the ulnar side. So you could have a Keen box, you can have ulnar impactions, ulnar impingements, and other reasons why you can get tenderness on the ulnar side of the Lister's tubercle, distal to the tubercle. But right in front of that, if you get it, it should be a carpal instability, a scapholunate instability. How will you find that out on an X-ray? Is to ask the patient to clench his fist very tight. So what you're doing now, remember that photograph of the load on the head of those little cartoons? When you load the capitate onto this joint, what will happen if it loads there? Then you will get something like this. So you can now provocate this change in the carpus, and you can then see a scapholunate dissociation. So you can ask for a clenched fist PA view or a clenched fist AP view, whichever one you're comfortable with. A lot of books say you should do it in the AP position, but commonly it's done in the PA as is seen here. So there are different types. You may not see this split so much. That is a pre-dynamic one where there's only ligament stretching and synovitis and pain, or there might be a complete disruption where you can still repair it. So it's a dynamic one which opens out and closes. And finally, these changes can get fixed, and then you're completely irreparable with cartilage damage as time goes by. That becomes a static SLD or scapholunate dissociation. So there are three types of scapholunate dissociation. One which will require an arthroscope to find out or an MRI to find out, and the other two which are quite evident. Clinically, when you look at this, you need to do, we've found the point of tenderness already. We're going straight to the Watson test. Now, what is the Watson test? What you're trying to do is now the scaphoid and the lunate have left hands. The scaphoid has flexed. Now, if you try and push the scaphoid back in and try and do radial and ulnar deviation, because there's no support there for the scapholunate ligament is torn, the scaphoid jumps out of the radius cup. So it jumps out of the cup of the radius, and therefore it will present itself on the back of the wrist. And how you would do that is by pressing down on the tuberosity of the scaphoid, which is, if you feel your pisiform and run your finger radius side, you'll feel another bony prominence. That is the scaphoid tuberosity. So you press the scaphoid tuberosity with the wrist in complete ulnar deviation, and then bring it into radial deviation, as will be seen in this video. This is a case where the patient's, this is the starting point. You can see my thumb is now pressing this tuberosity, and you can see the scaphoid, the lunate is here, and the scaphoid is sitting at the back there. Here, it's well contained.
Please unmute yourself, sir. Yes, sir.
Can you hear me now?
Yes, sir.
Sorry about this. I don't know. There's a lot of problems today.
We also have a storm brewing here, so I was wondering whether it was on our side or yours.
We've been having a really very, very bad weather for the last 2 days. It's been
I know,
flooded.
I heard about that, yeah.
Yes. Sorry. So I'll
Okay.
continue. Was the Watson test audible?
Yes, sir. Watson
Okay.
test you explained.
Right. So we'll
I
go
think
ahead.
maybe just start from there because that's when the problem started.
Yeah. So this is what happens. The scaphoid flexes. The lunate starts looking up. We saw that was a DZ, and then there is a clunk and there's pain. So remember, clunk and pain are most important to also understand. You can ballot the scaphoid and the lunate, and that's easy to do. That's easy to do. Now you know where the scaphoid and the lunate are, and you just ballot the two. The other thing you do is you can take a little traction view, and you'll see, because the scaphoid and lunate have left hands, that they will start moving apart from each other, and the lines of Gilula will be disrupted as seen here. The common sign that everyone talks about is called the Terry Thomas sign, and he was a comedian, and a British comedian who did a lot of serials when we were in school and college. And he had a gap in his front teeth, and it looks like the gap in between the scaphoid and the lunate, and therefore it's called the Terry Thomas, and it's known by many other names of people who have had gaps in their teeth in the front. But it basically needs a clenched fist, as you can see in this X-ray. This is a clenched fist view, otherwise you're not going to see it. The ring pole sign is basically, you can see a scaphoid signet ring when the scaphoid flexes, because it's the tuberosity that's overlapped now. And this point between the ring and the proximal pole is less than 7 millimeters if the scaphoid is flexed. But you need to get proper X-rays for this, and you need to get X which are 100%, so that when you measure off, you're seeing exact millimeters, because this cannot be otherwise measured. So it's best to measure it on the computer if you have digital X-rays. So what you would do is to try and immobilize the patient in the position where you would immobilize this is with the wrist in a little bit of dorsiflexion, and and usually most of these symptoms will settle down. You can stabilize them, as some people have done, and you should get fairly good results. But once it becomes a dynamic one like this, then you need to open and repair it, either with anchors or like we did in the old days with sutures, which was not strong enough. They would tend to get, but they would give you good results. So this is the patient after 2 years with a little bit of a gap still there, but completely pain-free and full range of movement, as we saw there. When it becomes chronic, it becomes a little more difficult to treat. And here's one where, if you see the clenched fist view, this is what happens. Can you imagine that and that? So this shows you the dynamic way in which the capitate pounds down on the scapholunate joint and opens it out completely. And this one requires a very complex ligament reconstruction. The old Brunelli procedure could be modified. It's called the 3LT procedure by Mark Garcia Elias and others. And you need to pass a strip of the FCR through the scaphoid from the dorsal aspect. So that's going in from here, come out from the dorsal aspect and recreate 3 ligament tenodesis, as it's called. It's a very complex surgery, but it gives you fairly good results. There are new modifications to this, which take care of the volar side by tunneling these grafts through the scaphoid and the lunate and the triquetrum and bringing it back onto itself. So that makes it a little more complex. You need to then hold this down, and you can see 2 little anchors there to keep the tension between the scaphoid and the lunate. The main point being to keep the scaphoid in extension, as can be seen there. And this is after the wires were removed. The scapholunate angles have been maintained, and you can see that the space is now well reduced. And a fair, pain-free range of movements with good grip strength can easily be given to such patients. Let's move on to mid-carpal instability, very rare. You have to be very, very vigilant to try and catch these. But a lot of patients will come and tell you when they go into ulnar deviation and in palmar flexion, there's a lot of pain and there's sometimes a clunk. And what you can do is do what is known as the Lichtman test, where you load the capitate down. So that's pressure on the capitate, and you bring the wrist into ulnar deviation and flexion. So you might hear a clunk as seen there. This is instability between two rows. So this is a CIND. There's no dissociation amongst the rows, but it's dissociation between rows. And it's very rare. Commonly, you might find in hyperlax patients, patients who tend to be much more lax, like Ehlers-Danlos, or even those who have, the contortionists and those who can stretch their thumbs down like this. Those Baton scores, higher Baton scores, those are the ones that can have clicks and clunks, which are normal, which are not painful and do not cause any problem. So you should have a symptomatic painful clunk, and only then are you going to try and get these investigations done. We'll see how it clunks. This is a self reproducible one, very painful, and every time he uses the mouse or if he turns pages in his book, he finds a lot of pain. He's a young boy and he needed to be reconstructed. You can see what's happening inside because the ligament is gone. You can see clicks open now. There you can see it clicking open. So that is what's happening. You can shear the two bones and you'll find like the allotment, and you'll find that it's painful and it might click. So you've got to be again very careful about that. You need to hold the right bones by palpating, feel for the hook of the hamate, and you can feel the triquetrum on the dorsum, and between the two, when you shear it or you allot it, you should be able to get excess movement with a lot of pain. This is not a patient. This is one of our theater assistants whom I just used for demonstration. Now, the next thing that you need to see is that on the X-rays, it's very difficult to find these. But if you look at the position of the lunate, you'll understand that there is something when it clunks, the lunate just suddenly flips to another position. And that gives you an idea that between two rows, there is a problem. So you can do fluoroscopy or arthroscopy and try and confirm this. You can repair this using a strip of the ECU, and various other techniques are there. And you can then fix it down and get fairly good results. Various other minor, extremely rare instabilities which we won't touch upon. So there's ulnar-sided, there are many other instabilities which, even if you diagnose, you're not too sure whether you need to go in and do major procedures. So you end up doing partial wrist fusions for these kind of painful conditions which you identify by clinical and imaging techniques. We will now look finally at perilunate injuries. Number one, the history is something that's extremely, usually comes with polytrauma. When they come with polytrauma, with a history of a high velocity injury, there's a lot of swelling and it's usually missed because you're looking at the patient for the head injury, abdominal injury, or fracture femur or pelvis or spine or whatever. And the IVs are pushed in and there's a lot of swelling in any case because IVs are out and the patient is in shock and things like that. You get to see them much later when they complain of these pains, etc. So you must, when you see something with a lot of wrist pain and swelling, you must ask of the nerves because that will give you an idea. So median nerve symptoms sometimes, or even flexing the fingers becomes extremely painful because if there is a perilunate dislocation, this is what happens inside, and you can see the lunate jumping out and pressing down on the nerve and clinically damaging the nerve so badly. So that's the lunate there, and that's what happens when it jumps out. So when you're seeing a perilunate, remember the median nerve is very, very, very much at risk and can be injured and needs to be decompressed. Otherwise, you're going to have a lot of nerve. And this is how it looks, very innocuous. You just see a little bit of swelling there, a fullness there, with a bit of swelling. But if you examine him in detail, you'll be able to put pressure right at the point where the lunate is meant to be, and you'll know that there's a bony prominence there, which shouldn't be there, as well as there would be pain. What is happening is basically slowly all the supports around the lunate are giving way. And as these give way, the change in the position of the lunate vis-a-vis the capitate is what we are looking at on your x-rays. So if you pay attention to the first one, you'll understand this is known as the progressive perilunate instability pattern, where the scapholunate ligament goes off first. And as that goes off, now you can see that the scaphoid moves away and the capitate starts extending. When you fall on that outstretched hand, slowly the volar ligaments start giving way, allowing between the capitate and the scaphoid and the lunate has already moved apart. That's the dorsal ligament there. That allows the capitate now to move behind. And once that happens, you start getting the distal row moving over the proximal row, finally falling down on its head and pushing it out from inside the cup. So it's a spilled E-cup sign, or you can see that the position of the lunate changes completely. Now, you remember the two ligaments that we spoke about, the long radiolunate and the short radiolunate ligaments. These are that continuously hold on to the lunate and don't allow it to go away. Very rarely will it break off. So, but it can happen, but it's very rare for that to happen. They are a very strong ligament. So they just hold on to the lunate, and therefore the lunate flips on that pivot. If you look at it from the AP type of position, this is what happens first. This injury then spreads towards lunocapitate dissociation and then goes on to the ulnar side and then allows the lunate to completely free from both sides and move on. So these two ligaments are the ones that are holding onto the lunate till very end. So identifying the injury, when you see the lunate in a triangular form, like an onion, you know that's not the shape of the lunate. So therefore you start looking a little more carefully. And when you look at the lateral view, the x-rays sometimes are very confusing because it may be just a scaphoid fracture. Is there something else happening? So what you need to understand is to keep a visual impression in your head that this is an MRI which shows the radius, the capitate, and the lunate and the capitate are all collinear, right? So when they're collinear, they look like a cashew nut and a loudspeaker. So they're all together. So if the loudspeaker is within the cashew nut and the cashew nut is with the radius, then everything is fine. And this is how the x-ray would look. So you can look at the radius, you can look at the lunate and at the capitate, and you'll find this is what it looks like. But if there's a dislocation, if the scaphoid has now, if the lunate has now flipped over and the capitate has jumped off, that's what you're going to get in your CT scans, and that's what you're going to get in your x-rays. Pretty clear now. When you look for what you're looking for is for the loudspeaker and the cashew nut, and you'll find that the kaju is completely flipped over and the cashew nut is sitting on the dorsum. This is a common variety. You also get a volar variety, which is very, very rare. Now, if the injury has gone around the lunate as we saw, then it's called a perilunate or a lesser arc injury. And some people call it the lunate dislocation, but other times it involves bones. It will involve the scaphoid, it might involve the distal radius, it can involve the capitate, it can involve the triquetrum, it can involve any of these bones or all of these bones. And then it's called a transcaphoid perilunate, transcapitate perilunate, or a transcaphoid transtriquetral perilunate, depending upon which other bone is involved. And this is now a large arc of injury, which means many structures are involved, including these bones, and therefore there's going to be a lot of morbidity in these. And this is how it looks. So you can see that it takes the triquetrum as well as the scaphoid in this one. And usually the scapholunate ligament, if the scaphoid is broken, that is where the injury has gone through. The lunate will remain scaphoid. So they have not left hands, but the scaphoid is broken off. And therefore the scapholunate ligament is intact. This is something that you must remember when you're treating them. Very rarely, and this is Dr. Anil Bhatia's case, the scapholunate dissociation can occur along with a scaphoid fracture and a perilunate dislocation. It's rare, but you must look for that as well. Then you need to then pay attention to the scapholunate ligament as well when you put the scaphoid back. And this is the rare volar transcaphoid perilunate, where you can see even there's a fracture of the lunate and the capitate has slipped down to the volar side. You can do a close reduction in these, but they are usually unstable, require further pinning like we did in this. Pinning sometimes is not just adequate. You might require to repair these ligaments. You'll get a fair degree of movements, but remember, don't promise 100% because it's taken away a large number of those ligaments in the mid-carpal area, which is an extremely important area. So you might require to repair the ligaments as was done. You have to use anchors and you can get a good result. And again, you can see there's painless function, good dorsiflexion, but yes, some restriction of movement. So always warn the patient of this. When they come late, you might find that it's more difficult and you might require to do a distraction first to get correct treatment. So sometimes you can get, you will always have some restriction of movement. So remember that always promise the patient, tell the patient that you're not going to be able to do a lot of things, but you will get painless and a fair degree. 70% of the movements can be got in these injuries if treated early. Adaptive deformity, this is what happens when you have a distal radius extra articular fracture, where the lunate is now looking up, it looks like a DZ. And to keep the wrist in the same, the fingers in the same plane or collinear to the forearm, see what happens to the capitate, it flexes forward. So therefore it corrects it. Now why should there be pain then? The pain comes from the stretching. So as you stretch into palmar flexion, there's traction on the dorsal ligaments there, and that can give you pain. There's impingement here, and you can get pain from that. So therefore, these are the two areas from where pain will come when you have an adaptive carpal instability. So you want to correct this, you need to do a corrective osteotomy of the distal radius, and you should be able to correct that. So carpal instability can be understood. At least the basics can easily be understood if you know the few ligaments that are important. When disturbed, these injuries can cause a lot of morbidity, severe stiffness and pain, loss of function and grip strength. The grip strength comes down to 20 or 25%, and that's extremely, extremely difficult to work. They can't do too many things. If you treat them early, if you identify these and treat them early, they can do extremely well. When you treat them late, and if you're reconstructing the ligaments, the operations are a little more complex and need to be done by experts. And the outcomes are fairly good, but once bone rubs against bone in an odd position where it's not meant to, those cartilages are not strong enough, you're going to find that this will cause arthritis in the wrist, and therefore you'll get slack wrists and arthritis in the wrists that could rob the patient of function. So you need to identify them early and treat them early. Well, thank you very much for your attention.
Great, Sudhir. That was fascinating as usual. In spite of listening to these talks so many times, it's always great to listen to it again. And I'm sure the DNB guys will have a lot of questions, or the PG students will have a lot of questions to ask of you. So Janki, can you get on with it?
Yes, sir. So regarding this thing, sir, you told me about that it is 3 types. That is carpal instability dissociative, one is non-dissociative, and another one is combined.
4 types.
And the 4th is the adaptive.
Adaptive, okay, sir.
Yes.
So, sir, this one example, if we can think of, that is dissociative type is DC and VC.
So dissociative means the scaphoid and lunate have moved apart.
Yes, sir. So one example.
Scapholunate dissociation is a CID.
Okay, sir.
Right. So when the scaphoid and lunate move apart,
within the same row.
So instability means that these bones are not in their normal position and the ligamentous or the soft tissue connections between them have changed. When it's a fracture, it's a fracture. But when it's the soft tissue that allows that to happen, and if it is abnormal. So in a lot of patients, if you stretch your wrist, if you stretch your finger back, and if you can come all the way down there, then you'll be able to do all these tests and get them positive in that patient without any pathology. Elasticity of the ligaments is what is important. So when these ligaments are torn, that's when these bones are not under control then. And that's why it causes instability, and therefore it causes pain and arthritis in the long run.
So, any questions from the DNB students? Thank you.
Yes, sir. I will just start, sir. If you have any question, please ask right now. Sir, and one thing what I understood about non-dissociative type is that mid-carpal instability, or is it mid-carpal and intercarpal instability same, sir?
Pardon?
Sir, mid-carpal instability and intercarpal instability is same, sir?
Intercarpal instability can mean any of the bones. But when you say the mid-carpal, you're specifically saying the proximal row and the distal row are, there's an instability between those two rows.
Okay, sir. So, because once they have asked for intercarpal instability also in the exam, sir.
So that includes both types, I guess.
You will talk about both the CID and the CIND as well.
So that is combined type, sir.
No. It includes CID, CIND, and combined.
Okay, sir. And about perilunate dislocation, sir, is it combined type, sir? CIC, it means?
If the lunate alone moves out,
okay, sir.
It has to be, it is a combined type, because if once it moves out, it has already changed its alignment with its own row. And when it moves out downwards, then its alignment with the capitate is also gone. So between the two rows also there is. So within the row and between the two rows. So therefore it's a combined or a CIC.
Sir, what I understood about that lunate dislocation, it is one type of perilunate dislocation. That is type 4. Is it okay,
Correct.
Sir?
Correct.
Yeah, it's in stages, okay? They are stages of the same injury. Okay, so when you fall on your wrist and you hyperextend your wrist, you start with the capitate extending, the capitate coming out, and as it comes back, it sort of pushes the lunate out in the front. Okay, so you have different stages. So when the lunate is out in the front, it has already gone through all those other stages before you get to that stage. So.
And one more thing I have cleared in this lecture, sir, that arc of Pilula and that lesser arch and greater arch is different.
Completely
it is
different.
Yeah,
Completely
because that is also
different.
Confusing, sir, during the exam.
So the arc of Gilula is just the lines that you see.
You see on the X-ray?
Yeah. It reminds you that these bones are in line.
Okay.
So when you look at an X-ray, you look at those lovely bangles, 1, 2, and 3 lines. Unless you take a proper X-ray, you're not going to get it. To get a proper X-ray, you need to keep the wrist like that at the level of the shoulder and the wrist. The level of the shoulder, elbow, and the wrist should be at the same level. If you're doing it like this or like this with angulation, then you're going to get different. You won't be able to see the arc of Gilula. So you need to keep a proper technician to get you standard X-rays. Only then are you going to see the arcs of Gilula.
Gilula is a radiologist, not an orthopedic surgeon. And he was here in India for a meeting some years ago, which was organized. It was I don't know, Sudhir, did you attend that skeletal radiology meeting?
No, I didn't attend that.
Where they had all these guys, including, what's his name? The guy who's written that book. And Gilula was there. He walks with a cane and he's the one who's described these arcs.
Mm-hmm.
And so one thing I also want to ask, that there is 3-column concept given for wrist bone also, sir.
That's
the 3-column concept is, see, that's what, then lots of columnar concepts.
Yeah.
There's 3-column, 4-column, there's 2-column. It started out with 2 columns, radial and ulnar side. And So there's a lot of confusion. But when you look at the wrist, make the Lichtman's oval ring concept much better than anything else, because it just tells me that the distal row is nice and stable. The proximal row is moving, and the bridge between the two is the scaphoid. And that solves a lot of my thinking as to what I'm planning for which patient and what the pathology can be. So there's involvement of the scaphoid and half of this, and so it's a very confusing thing. So if you look at different columnar theories, uh, it helps you in looking vertically. But when you're looking at instabilities from side to side, rotary movements, etc., and which ligaments are failing, etc., then it's better to look at the oval ring concept, which allows me to picture what's probably happening in within the wrist.
Sir, one thing
Sir,
yeah, Avinash.
sir, I had a question. Sir, in the exams, you often get to write about this lesser arc and the greater arc and the injury sequence that it follows. So in the slide that you showed that had multiple ligaments interconnected, can you just show us and explain us the lesser arc, greater arc, and the injury sequence that follows, like the radioscapholunate ligament and then the mid-carpal joints, and then the last lunatic tissue?
Amit, did you miss the talk altogether?
No, sir.
Sir,
Just want to see it on the slides.
Want to see it again on the slides.
It was shown multiple times. Yeah.
Sorry, I'll have to look again.
Years of.
What's going on? Can you see this? Are you seeing the slides now?
yes, sir.
Yes, sir.
Can you see this, Amit?
Yes, sir.
Yeah, can you see this? Are you seeing the slides or not?
Yes, sir. Slides are visible.
Yeah, visible. I don't know why it's not going into full. Yeah. So this is a very simplified way in which it's spoken about, and some books mention this. Although the sequence of injuries will depend upon how you fall, with if you're falling in dorsiflexion, with pronation or supination, it makes a big difference as to which ligaments are going to be strained, and accordingly the failure pattern will change completely. But this is what is commonly thought, that the scapholunate dissociation first occurs, then the lunocapitate dissociation occurs, followed by the lunotriquetral dissociation, where even the hamate then gets moved off. And finally, because the lunate is now free to flip on the short and the long radiolunate ligaments, it falls forward while the capitate then assumes its place proximally. So this is the common way in which it is explained, while this is the other explanation, which is where the first you find that the scapholunate dissociation occurs on the dorsum. The dorsal part of the scapholunate ligament is the strongest part of the scapholunate ligament. It has three parts. So when you're writing about scapholunate injuries, you must remember that the scapholunate ligament has three parts: the dorsal, the palmar, and the proximal part. So the proximal part is more or less fibrocartilaginous. So when you look at the wrist, when you open the wrist in surgery and you look at it, you're looking at the dorsal part, and it looks, typically you cannot make out the scapholunate joint at all, because it looks like one cartilage across. When you put in a small needle, you'll be able to find the space in between. The dorsal part is the strongest part, is a very thick part, and the volar part is more thinner and more delicate. So once that is gone, then the next ligaments that would go is the radioscaphoid ligament, radioscaphocapitate ligament, allowing this capitate now to move free, finally allowing it to push down. Once the lunate side, the triquetral side goes off, then the lunate is now free to move forward. So this is the sequence in which the three ligaments that you can remember, starting with the scapholunate ligament, going on to the radioscaphocapitate ligament, and finally the lunotriquetral ligament. In this sequence, the failure will occur.
So, and another important thing here is that we see a lot of them coming late because the injuries are missed altogether. So very often, so in this stage where the lunate comes out, the capitate actually fits beautifully into the distal radius. So if you are not on the lookout to see where the ulna is, when you just look at the X-ray, it might look almost normal. Similarly, in the second stage, the capitate might be behind the lunate. And again, you will not see unless you're looking out for the arcs clearly, okay?
Correct.
So
Correct.
these get missed and we get them late, and then it's a real problem dealing with them. So you have to be really careful in your initial X-rays to look at them and do further investigations if you're not able to assess the X-rays, okay? So I think that's important. If you can't assess the X-rays, I think today you have CT scans. If you have doubts, get a CT scan and it will be pretty obvious to you. But ideally, you should be able to pick them up on the X-rays itself. You see a lot of these missed. I don't know, every 2 or 3 months we get one of these coming 3 months
Yeah.
later.
And when they're late, it's so difficult to treat them.
Yeah, and you must be seeing even more because you're concentrating on that.
And sir, I was asking about that column concept. Sir. So for perilunar dislocation, that central column is important. So for that one, we should know the column concept, right, sir?
Yeah, column concept is, so it depends. If you're talking about the distal radius and ulna, so then the importance of it is because each column, the 3 column now, they have a 4th one added to it because you divide the intermediate one, but is that each has a different function, okay? And you have to understand that when you're treating these injuries, okay? So, and you have to look out for that intermediate column, which is often sort of collapsed, so you get a die punch fragment in that column, and that again is missed, and then you don't, when you're fixing them, you forget to deal with that depression, and then you end up with problems. Yeah.
And sir, for this thing, perilunar dislocation, what all X-ray we should advise, sir, for patient to diagnose it? Is it
For a perilunate, you just need
Simple.
a AP and a lateral view. In the AP view, like PA view, in the PA view, like we saw, the lunate looks like a onion.
Onion, yeah, just
triangular.
the shape of the
otherwise, the usual shape of the lunate is gone, and it's looking, because it's flipped over. And in the lateral view, you're going to see the lunate looking either down or up, so DZ or VZ, depending upon whether it's a dorsal or a palmar dislocation.
It's just awareness of it and a high index of suspicion, because people look at the X-ray and say, oh, distal radius is okay, this is okay, so no fracture. Huh? But you have to look at the carpals and concentrate on that as well.
Sir, you stressed upon one fist view for Terry Thomas side. So that in which case, sir?
In scapholunate
clenched fist view.
The scaphoid and the lunate are like this, and the capitate is sitting on top. So when you clench your fist, all the load that is there is pushed down onto the carpus. So when you clench your fist, and if you can lift 50 kilos with your hand, when you're lifting it with 50 kilos, when you're lifting it up, what happens is all that load has to be transmitted to the radius and ulna. And that load is transmitted through the central column, that is through the 3rd metacarpal down to the capitate, to the lunate, and then onto the lunate facet of the radius. The capitate is now on top of the scapholunate joint. So if the scapholunate joint is not good, if they have left hands, if they have torn, then the bones will move apart. As soon as there's pressure there, the bones will move apart, and therefore you're provocating the injury. You're trying to make that gap wider by loading.
Yeah, because if you just take the X-ray, you may see the gap when if it's an obvious disruption, but it may be normal. It's only in stress that the gap appears. It's like a stress X-ray for
For the shoulder, you take with weights in the hand.
Okay, sir.
You can
AC
see
joint or the
AC joint.
distal tibiofibular joint. Those things you sometimes need to stress it to view it.
So when there's instability between the two ligaments or between the two bones, you're trying to push them apart by getting the capitate to punch in between.
And when we should order that other investigations like MRI, CT scan, or arthroscopy?
See, the thing is, arthroscopy is coming in a big way in even in our country. A lot of people are doing. I don't do wrist arthroscopies, but a lot of people are doing wrist arthroscopies, and that will give you a direct view of what's there, and instabilities are easily identified. Even these subclinical ones are easily identified on arthroscopy. So that comes as one of the diagnostic techniques for these obscure or hidden ones. But the fairly obvious ones, X-rays followed by stress views, fluoroscopy. So you can actually see the Watson test and the clump.
Dynamic view.
Yeah, so you can actually see that under fluoroscopy, but you need to be very careful of positioning and not moving in rotations when you're doing it. You've got to be very careful, and you should be mindful of the amount of radiation that you yourself and the patient are taking. Then CT scans, again, CT scans now they're doing in different ways. They do the CT scan with the stress and without the stress. So you can actually see differences. So it gives you a better idea. And you can then ask for an MRI. When you ask for an MRI for the wrist, specifically, it should be at least a 1.5 Tesla. Best is a 3 Tesla. If it's not available, then it's okay. The slices size should be 2 millimeters or less. The area of focus, there are 3 or 4 things that you need to tell the radiologist. So otherwise, they'll take an MRI of the whole hand with some part of the wrist, and it's just a waste. So you need to have what is known as wrist coils. So there are coils to try and concentrate the rays so that you get a far better image. So you have wrist coils, size of slice, and the strength of the machine, 3 Tesla. So when you have all of this together, you can actually, and now they have what is known as ligament sequences. Cartilage sequences. So they can actually tell you the thickness of the cartilage with a 3 Tesla machine. That's very much something that a lot of people will tell you. So why you want to know the cartilage health? Because if you're going to do a reconstruction where cartilage is already worn off, you can get arthritis very soon. But if the cartilage is thick and healthy, then you do a reconstruction, then that will give you painless function for many, many, many years. So 15 to 20 years, you can get painless function. I have boxers who scapholunate, that's a very common injury in boxers. I have boxers who scapholunate injuries chronic. They don't come to you initially. We've reconstructed using these ligaments, the 3LT, and they've gone back to boxing with almost full range of movements, and they're back at their positions in the national and international listing. So it can last for a long time if the cartilages are good. So that is where the importance of the MRI comes in. The importance of the MRI would come in when you're looking for ligament injuries. But again, you need to have very good MRI machines and a good interpreter, because the sequences that are taken normally are taken by the technician. So when you want something specific, if you're looking for torn ligaments in the wrist, please ask the radiologist to be there himself to give you good images. Then he can interpret that. Very early in the injury, there's a lot of blood, there's a lot of fluid inside, reaction is too much, you will not get good images. So you must wait for a little time if you're doing these for finding out the ligament injuries.
Also, I think the other area where MRI helps is the TFCC, which are very difficult to assess properly otherwise.
Sir, I have read about in arthrography that they have written some 2-compartment arthrography, 3-compartment arthrography.
When
What is
we
that?
were students, we did a lot of arthrography.
That's
We shot in a lot of dye into various places and were very happy. We spilled dye all over the wrist and we got beautiful X-rays with lots of dye spilling around, and we went around telling people that we did arthrograms and we couldn't interpret anything.
yeah.
And funnily enough, in those days, we never opened the wrists. All we did was find out that it was torn and just leave it alone. But I don't think many people do arthrograms now. Very specifically, in one or two instances, we might do it. But otherwise, generally, arthrography can be avoided.
Sir, I wanted to know about a scaffold unit advanced collapse. When we say a scaffold unit advanced collapse wrist, does it mean it is equal to osteoarthritis wrist, or it is different?
Osteoarthritis is the last stage of scaffold slack wrist. SLAC is the scaffold unit advanced collapse. What happens if you do not treat a ligament injury? It just goes on and on and on. Now, like I said, surfaces that are not meant to be moving against other surfaces have now suddenly changed, and therefore some wrong surfaces are rubbing against wrong surfaces. So they're not congruent surfaces, and the cartilage sizes vary. So you are going to get wear and tear in those regions equivalent to arthritis. So a slack wrist is, yes, and is a progression from a ligament injury to arthritis. And there are grades of those.
Sir, in the treatment of slack wrist, is there any role of surgery?
Oh, yes. Oh, yes. A lot. So you can, in early stages, slack wrist again follows a certain pattern. So initially you'll find changes happening in the stylocarpal joint, means the radial styloid and the carpus at that level. So when everything is restricted to the scaphoid facet of the distal radius, you can do a styloidectomy and you can do a reconstruction. You can do a reconstruction where you can have capsular flaps in between if it's early stages. Once arthritis begins, then you're looking at excisions of the scaphoid, or if you're looking at if you're doing a slack wrist, you're looking at if the you can do fusions between the scaphoid and the radioscapholunate fusion, the radiolunate fusion. You can excise the scaphoid and do a four-corner fusion. So there are different surgeries that will retain the lunate facet and will allow some movement, painless movement, almost up to 60 to 70% of the normal function of the wrist. So surgical treatment is there. You can do neurectomies. So you just want to take away the pain. You know there's arthritis. You don't want to do surgery for the arthritis at that stage. You can take away the pain. So you can do a neurectomy and give painless wrist. But then you're creating something like a Charcot joint, which might progress faster. But without pain, he'll get good function in his in the years that he's going to be productive. Afterwards, you can do fusions as and when required. So there are different fusions which can start from the smaller fusions and go on to being the fusions that would involve the entire wrist. That means the radiocarpal fusion.
Great. I think that's
one last question regarding, sir, you mentioned about one dynamic stability and static stability. So in exam also, sir, sometimes they ask for wrist biomechanics or kinematics. So what in that this is right, sir?
Wrist kinematics for the exam, I really am. It's a bit too much to expect at that time, unless a certain pathology is given. If they give you the pathology of scapholunate dissociation and say discuss the kinematics, then it's so easy that you know what you're doing. But if they just tell you wrist kinematics, it is all of what I spoke today about the midcarpal joints, about the ranges, about the ligaments, so you talk about where those movements are occurring. And you can then also bring in, if you want to, if it's a long question, if it's a full question, then you need to bring in the extrinsic stabilizers of the wrist, which means the long muscles that go across the wrist and what their functions are. So then you can bring in, because all of this has a lot of importance in the rehabilitation and in the position of immobilization, etc., when you're treating wrist injuries. But it's a very, I think it's a very cruel thing to ask wrist kinematics in an MS exam or an NP exam. Because
it's like asking biomechanics of the hip or something like that.
But since if you go through this lecture, if you listen to this lecture and if you paid attention from the beginning to the end, we've got 3 or 4 conditions that we discussed, and most of it can be interpreted as wrist kinematics.
Yeah, starting with
those two videos of the wrist movements, that itself, when you describe it with that engine and the cam effect and how the scaphoid bridges the proximal and the distal row. So you've got so much to write, and whenever you write and you want to attract attention of the examiner, then underline some things that you know are certain and then change the paragraph and then move on. So when you write like that in blocks, it looks like you put across a large amount of information.
Yeah,
but otherwise it's very boring otherwise to read wrist kinematics, and to try and memorize anything is impossible.
And in wrist kinematics, you have to start from normal. What are the normal, then talk about what happens when you have the various dissociations, instabilities, etc. So it's like almost a whole chapter in a book, literally.
There's something, now that you've asked, I'm going to just give you something more that you can write. And there's something that's known as a catch-up clunk. Now, I spoke 2 or 3 times about the elasticity of ligaments. So if you think of a little child walking in a park with the mother or the father, the steps of the father is much bigger than that of the child. So as the father takes 3 or 4 steps, the child has to take 6 or 7 steps. But usually the child is little behind. So the father is holding the hand behind like that. And the child then suddenly runs 3 or 4 steps and catches up. So imagine the same thing happening between 2 bones in that movement, where one starts moving, the ligament is now getting tighter and tighter and tighter, and then suddenly this goes up. So this is known as a catch-up clunk. So very often, a lot of patients can, do their movements like that, and at some stage it will be crack, you'll feel a clunk. And then you're in the exam, you're tense, you're worried, and you hear this clunk and you think, wrist instability. Examine the opposite side immediately. Check the elasticity.
Ligamentous plasticity.
Once you know that this is a hyperelastic person or a slightly more flexible person, then there's a chance that this is a catch-up clunk because he has no symptoms or no pain. So a catch-up clunk is a normal thing. It's basically because one bone moves further out during a certain movement and the other one is lazy to come because the ligament can stretch so much. At a particular point of the stretch, it's like the rubber band is now tight enough and now it can't get tighter unless it breaks. So then the bone then just slips and comes. So then there's sometimes a little clunk over there. So it's known as a catch-up clunk. So you can write about catch-up clunks when you're talking about wrist kinematics.
Thank you so much.
I think it's already 10 to 7. Yep. So thanks a lot, Sudhir, and that was great.
Thank you.
And I'm sure people can go over the lecture again too if they haven't understood anything, and it's made things very clear for you.
Yeah, almost everything is covered, sir. Whatever they have asked.
Thanks for sending that message. Then I could organize my thoughts in exactly what you want.
Yeah, great. Okay, thanks very much, and we'll have you again sometime when we are talking about.
Thanks a lot. Thank you very much for the
coordination.
Bye-bye.
Thank you.
Okay, bye guys.
Thanks, sir.
Thank you, sir.